Proximal hamstring tendinopathies are a really common injury that you'll see in the clinic. The client will come in describing quite localized pain just underneath the fold of the buttock. It can be unilateral or bilateral, and the type of things that they'll describe are pain with sitting, pain with activity that starts sore, often warms up, gets better, and then gets worse towards the end of activity and certainly afterwards and the next day. It's quite a tricky condition to diagnose if you don't know what you're looking for, because there are so many structures that refer pain into the same area. And so a really careful examination is crucial. These patients won't be talking about neural symptoms like referral down into the lower hamstring or the calf or the foot. No pins and needles or numbness. They're talking about very specific localized pain to that area. And quite often they're still pushing through their activities. And they are the type of people who are typically engaged in either an increasing amount of activity and sport, so increased load, or they've recently returned to a sport. They can also be people who have recently started, let's say, a new job where they're sitting on harder surfaces and creating compression and pain through that proximal hamstring tendon.
Yeah, this is your active client. So these are quite athletic injuries, and it is a classic tendinopathy in terms of its presentation. Yet, as Caleb has said, there are a lot of referring structures into this area. And so one of your definitive diagnoses is that it is localized pain. As soon as a client starts talking about diffuse pain, you do not have an isolated tendinopathy, if a tendinopathy at all. And so you need to be hunting around for other causes of that, whether it be a piriformis or a lumbar spine, or even a stress fracture of a hip, which could sometimes present as a tendinopathy. And so find the tendon, it should be locally sore, and then we get to progress and treat it like the tendon that it is, and don't miss the diagnosis.
Yeah, so from a clinical examination perspective, even before getting them on the bed, I want to screen and clear the lumbar spine. And so I'm looking for movement through the lower back into flexion extension. And what I'm interested in here is not so much pain in the actual tendon itself, but if they're getting any symptoms into the lumbar spine and lower down. And so I'm actually expecting they will probably get pain in the tendon if it's tendinopathy. But if they're talking about lumbar spine or further distal referral, then I'm starting to be suspicious of the lumbar spine as a referral source through there. We're going through a quadrant extension and then coming back up. And then we'll come down into a prone position on the bed. And so, as Mark said before, the number one thing we're looking for is pinpoint specificity of tenderness over that hamstring tendon. So we're going to come up and find the ischial tuberosity where it inserts. You may also get bony tenderness into that enthesis where it attaches into the ischial tuberosity, but then also coming down. And I like to sort of flick over the tendon and palpate almost 180 degrees around the circumference of it. And if you have a patient who has a hamstring tendinopathy, this will reproduce their symptoms. I also like to do an isometric resisted muscle test. So as they contract through their hamstring muscle, they should get an increase in pain through the hamstring tendon. And once they're loaded, you can then repeat that palpation, and under the contraction, it will often be more sensitive. Now, in terms of ruling out things like a piriformis or a lumbar spine referral, in this position, you'll come down and do PA palpation through the lumbar spine vertebral segments, and you're making sure that this is not reproducing that same pain down in the buttocks. And then coming out to the greater trochanter, coming just inside and finding the piriformis and pressing onto that. Again, you're making sure that that's not reproducing the pain that they're describing, which is a little bit more indicative of piriformis syndrome. And then in supine, rolling onto your back, we also want to do a couple of tests for both hamstring and neural structures. And so here we're thinking about doing just a hamstring 90-90 to look at left versus right range through the hamstrings. And we're here again looking for perhaps pain through the tendon, but also a loss of range. And then we're going to compare that with a straight leg raise, which is again perhaps going to reproduce a little bit of that hamstring tendinopathy pain. But if you're getting significantly different symptoms from left to right, distal referral into the foot or the calf or back pain, then we're starting to think that it's probably more likely a lumbar spine radiculopathy or lumbar spine radiculosomatic pain that's coming down into that hamstring region. And so always doing the good side first, coming into dorsiflexion, lifting up, finding that point of resistance, and then taking it off dorsiflexion and comparing that to the opposite side to determine whether or not we actually have some neural involvement or it is in fact an isolated proximal hamstring tendinopathy.
Yeah, and I think, focusing on your treatment is again important. We talked about the trochanteric bursa before and the tendon of the common gluteal. It's your advice as much as your intervention strategies with this as well. This tendon is not going to like sitting. It's going to cause traction of the tendon while it creates compression. You're going to have clients coming to you and they would have been trying to stretch out their leg, generally speaking, as well. And so advice around the stretching of the tendon and its negative outcome for a tendon is going to be really important, because it does have that issue of both traction and compression around the ischial tuberosity. And so we want to go through a loading program, which we'll talk you through now, and making sure that we're getting really nice isometric loading in its inner range. The other things that you're going to see these people doing is they're going to be doing things like deadlifts, squats, deep lunges, and those sorts of things. And it's the repetition of trauma to the tendon, which is the creation of the pathology. And so it's the reversal of those activities, which is going to give you the first opportunity to get this client well. And so one of the questions you should be asking yourself is, why is it the right and not the left if it's on one side? And so having a look at those aspects of the body, the biomechanics, the anatomy that could be leading into that, so you can explain to the client on how to change that. So don't take for granted that it's just on one side and the loading program is going to improve that. You need to be able to understand the why. So we'll get into some loading now.
Yeah, so we've got some videos that will take you through a full hamstring loading program. But as always with tendinopathy, we're going to start with isometrics, progress into concentric, eccentric, heavy, slow resistance, and then eventually plyometrics. And as we talk about in the videos, never more than a 2 out of 10 pain with that. Always making sure that you progress slowly through increasing levels of load and then taking away all of those aggravating activities that could potentially create pathology even when you're doing the perfect loading program, and keep that tension on the tendon or the compression or the rotation on the tendon that's continually loading through it. And so, as always, with any tendinopathy, very strict protocols and taking away any of those aggravating factors. And of course, as Mark said, keep asking yourself why one side and not the other. If they've had increased load to both sides in terms of the exercise that they're doing, and one tendon's fine and the other's not, then there's probably some sort of biomechanical deficit within the body that's creating more load and torsion and force on the affected side. So as an add-on to our talk about proximal hamstring tendinopathies, it's also worth discussing tears to the proximal hamstring tendon. And so if you have someone who has an acute injury to the proximal hamstring tendon rather than that insidious onset of increasing pain, or if you have someone who is not responding well to your loading program and treatment for a proximal hamstring tendinopathy, then it's worth considering that there is an actual tear to that structure. And in this case, it's worth referring to your sports physician to get imaging. And the gold standard here is an MRI. And quite often with these, they'll need some medical intervention in the form of either PRP injections or, in extreme cases, a surgical repair of the proximal hammy tendon.
Yeah, and it's really important that if there is a significant avulsion of the proximal hamstring, that there's an early referral for surgery. These surgeons normally like to do the surgery within the first 6 weeks. And you'll often feel that. You'll often feel that there's a gapping of the tendon. And if there's a proper proximal hamstring tear, it normally takes some of the bone with it, so you'll get significant bleeding. So it's the high hamstring tear that has a lot of bleeding. You'll see a lot of purple there. As soon as you see that, it's straight to an MRI and referral to make sure that that person doesn't need any surgical intervention. And as Caleb said, there's some really good evidence now around early intervention with PRP, and we're seeing that really, really good results in our sporting populations with that. And that can also relate to a proximal or mid-belly hamstring tendon, which involves the central tendon. And so they're using PRP early, first 2 weeks of a central tendon tear, which is having really great effect on recovery of that collagen and earlier return to sport. So sometimes in our elite population, bringing 10-week recoveries down to 5 or 6 weeks.